Today, I'm going to share the clinical experience of MR-guided radiotherapy for gynecological cancers and future perspectives. So I'm going to start by talking about what's the role of radiotherapy in gynecological cancers with evidence support, and also discuss about image guidance, especially using MRI to guide radiotherapy in this group of patients. So in our hospital, we have a case series of using such technique for gynecological cancer patients. And with these case sharing, we can also appreciate the online adaptive workflow. Hypoxic biomarker using F18 FASA is a new trend, and one case will be shared. And lastly, I'm going to briefly discuss future directions. So for radiotherapy for gynecological cancer, I'm going to start with cervical cancer. It is indicated for bulky types of locally advanced stage 1B3 to 4A disease, and when upfront surgery is not possible. So external beam pelvic radiotherapy followed by brachytherapy with concurrent chemotherapy is usually advocated. For patients who received upfront surgery, postoperatively, if the patient falls into intermediate or high-risk group, then patients still require postoperative radiotherapy. So the use of intensity modulated radiotherapy or IMRT has been established as the standard of care for these patients. Dosimetric studies showed improved dose to the organs at risk, such as bladder, rectum, bowel, bone marrow, compared with the conventional 2D, 3D techniques. So the below table showed three phase 3 studies comparing IMRT versus 3D conformal techniques, showing there is a significant reduction in grade 2 and above gastrointestinal or genital urinary toxicities compared with the conventional techniques, while the survival outcomes between the two arms are similar. There is a clear relationship between dose, tumor volume, treatment duration, and the local control rate for these group of patients. The recommended dose would be also called the biological equivalent dose for 2-grade fractionation or EQD2. We should aim for at least 85 grade cumulative dose or above to the macroscopic residual tumor, and therefore, as part of the therapy, brachytherapy is essential. As you can see in the right side graph, treatment prolongation of more than 56 days actually could lead to a poor local control and a high recurrence rate due to the fact that tumor might repopulate and will have a lower survival. For uterus cancer or corpus cancer, radiotherapy is usually indicated for after upfront surgery for postoperative setting if they fall into intermediate or high-risk groups. In fact, for the intermediate risk group, vaginal brachytherapy alone, according to the PROTECT-2 trial, has been demonstrated to have equivalent disease control and less toxicity compared with external beam radiotherapy. While for the high-risk group, external beam pelvic radiotherapy are advocated. The PROTECT-2 trial has a 10-year follow-up showing both arms of external beam radiotherapy and vaginal brachytherapy groups have a very low vaginal recurrence. And pelvic recurrence at 10 years were also low, but with a slightly higher trend for the brachytherapy arm. Therefore, pelvic radiotherapy should be discussed with patients if they have unfavorable risk factors. So this is a landmark trial for uterine cancer for IMRT compared with standard RT, and this is the RTOG-1203 study. So for these patients of cervix and endometrial cancer who received surgery and received post-op radiotherapy, there's some comparison of IMRT versus conventional technique, and the primary outcome is a 6-item patient-reported outcomes, mainly focused on the acute GI toxicity. So this study showed significantly fewer gastrointestinal side effects with the IMRT arm with an 18% difference. Other indications for gynecological cancer would include ovarian cancer, which is at the oligo or limited less than 5 sites of recurrence, for example, involving periaortic lymph nodes, bone, lung, etc. Also, for vaginal or vulval cancer, primary radiotherapy for inoperable disease, usually stage 2 and above, or recurrence at the vault after uterine cancer upfront surgery are also advocated, as well as vulval cancer. Some patients who have risk factors postoperatively would also receive radiotherapy. So definitely the most important innovation in this group of patients would be IMRT. The rationale would be to reduce toxicity to bowel, bladder, rectum, marrow, acute and late side effects. And improving dosimetry enables simultaneous integrated boosting, or SIB. For example, having a pathological lymph node with differential dosing. For example, like the diagram on the right side, you can see that if there are patients who need to receive extended field radiotherapy to cover a long stretch of periotics to the extending from the pelvic nodal regions, then IMRT can also reduce bowel and marrow toxicity. Image guidance has been advocated as a new standard of care. And actually, in the context of gynecological cancer, mature evidence has existed for image-guided brachytherapy for cervix cancer. Multi-institutional study has demonstrated superior local control and survival compared with the 2D X-ray guided techniques. And this is indeed a pioneer to develop image guidance in other cancer indications. So using MR guidance, we talk about MR-Linac. So MR-Linac is a combination of linear accelerator or Linac with magnetic resonance imaging MRI scanner. So the caveat is using an online adaptive workflow, which means either adapt to position when there is no main difference in the contours, or if there is modification of targets needed, which is adapt to shape. So this is a typical online adaptive MR-guided radiotherapy workflow. First, at the stage of offline, which is radiotherapy planning for the patient, both CT and MRI would be done, and MRI determining the right and most ideal MRI sequence for each organ site in order to visualize the tumor best would be decided at this point. So with the registration, a plan after dose optimization would be created and called a reference plan. So the patient will be ready for treatment. So during each radiotherapy treatment fraction, patient after setup with immobilization will receive the daily MRI at the machine, which will be co-registered with the reference plan. If there is no major deviation, adapt to position workflow would be adopted, and the patient would create a plan of the day and proceed treatment. If there is modification, a deviation of targets that would require adapt to shape, new contours would be generated from the deformable registration, and also modification from the oncologist and radiation therapist would be done. And those re-optimization will be done, and a new plan would be generated. In the context of cervical cancer, this workflow is also demonstrating that on the top, since adapt to shape is quite common for cervical cancer, we usually would end up along the 25 fraction of treatment to have a few plans. So from the planning library, we can import the plan and correlate with the reference plan, which would evaluate whether a adapt to shape or adapt to position will be advocated for each treatment. If the online adaptive workflow is advocated and change of target and organ at risk is needed, then a recontouring, re-optimization, and re-dose calculation would be required. MRI guidance has advantages of excellent visualization of pelvic anatomy, and it enables daily adaptation of radiotherapy treatment plans. It can also compensate for motion and shape changes of targets and normal organs. There is potential treatment, therefore, that we can give a smaller safety margin and a higher dose with dose escalation. And MRI can also provide benefits to monitor the response. So an important study is called the Momentum study, which is an important paper that is just published last month. It consists of 900 patients from 7 institutions, 4 countries representing the MR-Linac Consortium group. Between 2019 to 2020, these 2 years. And the results shows that prostate, oligometastatic lymph nodes, brain, and rectal tumors are the 4 most common indications. And the median number of fractions would be 5, but it ranges from 1 to 35 fractions. There is a low acute toxicity of 4% noted. So these diagrams at the bottom also show that the median number of fractions from various sites is usually a hypofractionation, except for the oropharynx, which is represent head and neck sites, and also brain tumors, when more fractions of 30 fractions or above is needed. And from the table on the right side, we can also see that there is more adaptive shape required for organ primaries such as prostate, rectum, and lymph nodes, whereas for the brain tumors, it's entirely an ATP. An important paper is demonstrated from MR-guided brachytherapy for cervix cancer from Professor Richard Potter, which is also published this year, is the EMBRACE-1 trial. It recruits more than 1,400 patients with a demonstration that MR guidance in this group of patients can provide an excellent local control at 5 years of 92%, 5-year overall survival of 74%, and a very low grade 3 and above toxicity demonstrated. So this has established as a benchmark trial to change clinical practice. So studies in focusing on gynecological cancers have also shown that in terms of interfractional movement of cervix during IMRT, the movement in all directions are up to 5 millimeters from one trial. Therefore, without any online adaptive workflow, it is just being cautious to give a more generous planning target volume of 1.5 to up to 2 centimeters. However, it came at a cost for irradiating a larger volume of normal organs. Therefore, adaptive studies using cone beam CT can be shown to reduce organ at risk dose with reduced margin, according to another study. So this particular study have shown that if we are able to have online adaptive planning, using a CTV to PTV margin of up to 5 millimeters can significantly reduce the volume of normal organs receiving more than 40 gray by 47% for rectum, 59% for bladder, and also 30% for bowel. Another study has also advocated a plan of the day technique, which would generate a planning library of empty, full bladder, and also a backup plan to align the plan according to the daily cone beam CT. So in the recent 2 years, we can see that the MR-guided RT clinical outcome and toxicity mainly focus on abdomen and pelvic sites. And these studies have also showed favorable local control and acute toxicity data. But we should take note that some patients actually are contraindicated, may not be eligible when they have claustrophobia, required extended field radiotherapy for cervix cancer to include para-aortic lymph nodes, as we usually do not extend our field length of more than 18 centimeters. And patients who have poor bladder control would pose challenge because the treatment time and the couch time is relatively longer. I'm going to present a case series, which is by far one of the larger cohorts in terms of gynecological cancer, according to our previous discussions at the MR-Linac Consortium task groups. So cervix cancer occupies half of our patient cohort, followed by postoperative uterine cancer and recurrence of the uterine cancer, vaginal cancer, and there are also patients with isolated relapse from ovarian cancer. For the cervix cancer cohort, the stages are between stage 2B to 3C1. We contour using the EMBRACE-2 protocol, which delineates gross tumor volume, which is a cervical tumor or any pathological enlarged lymph node, high-risk CTV, and also the low-risk CTV. That should include the whole uterus, perimetrium, and upper vagina. An important concept is the internal target volume, in which we need to add 5 to 10 millimeters around to our clinical target volume low risk to account for movement during treatment. The diagram on the right side shows that different scenarios we need to adapt for the internal target volume, which might include on the top empty rectum, in the middle a full rectum situation, and also a full or empty bladder situation when we might need to modify our ITV margins. Another important clinical target volume in our cohort is the elective nodes, which would include the lower common iliac, external and internal iliac, presacral, as well as the obturator nodes. An important caveat is that we would usually separate 2 or more different planning target volumes, in which we would add 5 millimeter margin from the lymph node CTV and also the ITV, because as the adaptive to shape protocol usually is more common for the ITV part, and the lymph nodes are usually pretty static and do not have much movement. So the patients are usually set up with hand grip, headrest, knee and feet step. And another important point from our experience is that we do not usually put our patients in full bladder, or rather we put our patients in a comfortable bladder volume. And we have decided that 100 to 220 mils of bladder volume is sufficient, so that there might be subsequent bladder filling during the treatment. Dose of 45 to 50 gray in 25 fractions over 5 weeks are advocated, and there is simultaneous boosting enabled to pathological lymph nodes up to 55 gray. It's important to follow this MR-Linac treatment to MR-guided brachytherapy. So we have noted that adaptive shape is required for every cervical cancer patients from 1 to 7 times, and the room occupation time is on average 50 minutes. The timing of ATS could occur early on or at different stages of the 25 fraction of treatment. And the usual reasons include to modify the tumor because it's shrinking or shifted, modifying the high-risk clinical target volume or the internal target volume, and modify the organs at risk, body contour, or dose escalation of lymph node for one patient. So this is our unique workflow at the hospital, which combines the MR-Linac and the subsequent MR-guided brachytherapy treatments. We start with 25 fractions of MR-Linac treatment over 5 weeks with a hybrid ATS and ATP treatment. And it is also in a particular note that we would use a MR-Linac image on week 5, usually on the 21st or 22nd fraction, so that we can do like a pre-planning for our subsequent brachytherapy treatment. The second phase would involve an MR-guided brachytherapy workflow, which starts at the operation theater to insert applicators, MR scanning, and also if patients would need interstitial needle insertion and additional CT planning, dose optimization treatment, and removal of applicators. The average time for the whole procedure would take 5 hours, and patients can be discharged on the same day. The mean total dose to the high-risk clinical target volume is on average 92.8 gray, which is well exceeding the minimum required 85 gray dose. And the mean total dose to the organs at risk are also well within constraints. So I'm going to share a few cases which start with a 76-year-old cervical cancer patient, stage 2B, squamous cell carcinoma with a 5-centimeter tumor. After 5 weeks of pelvic IMRT using MR-Linac with a weekly cisplatin chemotherapy, she's then moved on to MR-guided brachytherapy. And on the picture on the right side at week 5, you can see a significant tumor shrinkage. So we're looking at the MR-Linac treatments at fraction 1. ATP is implemented because there is good correlation between the reference plan and also the plan of the day according to all the constraints. And the patient has been going on the ATP as there is also good alignment. And sometimes we would set a range of those constraints between 0.5 to 1 gray range, so that if the patient has minor deviations like the yellow light have shown, we can still proceed with the treatment safely within constraint. So for this particular patient at fraction 18, we have adopted adaptive shape procedure because we see a significant tumor shrinkage. So this is a serial review of patients showing that there is a significant tumor shrinkage to 50% during the 25 fraction of therapy. Although there are minor variations in terms of the bladder and rectal filling, we can appreciate that the planning target volume is still covering what we need to cover. So it is still a safe treatment. For the uterine cancer cohort, we have patients who are in stage 3, postoperative setting and recurrent setting. The need to adapt to shape is less, ranging from 0 to 2 times, and the room occupation time is slightly less than 45 minutes. The timing of ATS usually either early on or at the end of the treatment, and the reason to modify body contours and organs at risk. So this patient is a recurrent case and had 4 years ago stage 1 disease, but subsequently had peritoneal metastasis with chemotherapy given. Recently has isolated peritoneal metastasis with resection. So a whole pelvic radiotherapy of 25 fractions, 50 gray, and with a higher dose simultaneous boosting to prior surgical bed is enabled with the MR-Linac treatment. This patient is an ovarian cancer patient, 71-year-old, had 6 years history of disease from disease diagnosis, and with multiple times of periodic nodal relapse with chemotherapy giving good shrinkage of the tumor. This is followed by stereotactic body radiotherapy. So this is the plan of stereotactic radiotherapy given over 5 fractions, and ATS is required on fraction 2 because there is some contour change in the right side kidney, which is very close to our target. The last patient I'd like to share is a vaginal cancer patient, 56-year-old, small cell stage 1 cancer, planning for chemoradiation with whole pelvic radiotherapy and also simultaneous boosting to 62.5 grade to the primary tumor. So ATS is implemented at 16th and 19th fraction because, as expected, small cell histology, there is significant tumor shrinkage that requires modifying the targets. So I'd also like to spend briefly to talk about hypoxic marker, as tumor hypoxia is known to be a biomarker to predict radiotherapy resistance. PET using hypoxic tracers can identify hypoxic regions and serve as a target to monitor responses and outcomes. And these has been shown to be effective for head and neck, cervix, and sarcoma patients. There is a potential role using the hypoxia region for dose escalation and disease monitoring. F18 fluoroazomycin arabinoside, or FASA, has been shown from case series to be effective and safe. This 70-year-old cervix cancer patient is stage 2B, and baseline dual tracer PET have shown that within the avid cervical tumor, a smaller area of F18 FASA activity is shown at the anterior aspect, which is largely correlated with the baseline MRI pelvis. After 4 weeks of chemoradiotherapy, a repeat of dual tracer showed a marked shrinkage in size of the tumor and also no more FASA activity to substantiate any hypoxic area within the cervix. At the brachytherapy, it's noted that tumor has completely regressed with negative of malignancy noted, and 7 months afterwards, complete remission is noted. So future directions would be to adopt functional imaging using DWI and dual tracer PET for response monitoring, and also dose escalation for persistent uptake and also potential radio-resistant areas. Implementation of MR-guided imaging in the regular workflow of radiotherapy treatments can offer clear advantage to allow adaptive shape to modify target or organ at risk. It also allows margin reduction and to improve dosimetry. If resources are not feasible for online daily adaptive MRI for some hospitals, a consideration of a potential hybrid MRI as baseline and cone beam CT during treatment and pre-brachytherapy MRI can be advocated. Is there a role for proton therapy combined with MR guidance? Ongoing clinical trials may answer the question later. There is now implementation of disease types for international proton centers, such as using it in cervix, uterine cancer, re-irradiation, oligometastatic ovarian cancer, and also young adolescent groups. So I'd like to conclude by saying that innovations in gynecological cancer radiotherapy can enable better toxicity profile and improve patient clinical outcomes. IMRT with image guidance is clearly a standard of care and is well supported by clinical trials. Our institutional series on MR-guided radiotherapy and brachytherapy of gynecological cancers can demonstrate a variety of applications. Dual tracer PET, functional imaging for disease monitoring and prognostication can enable more optimal radiotherapy outcome. Ongoing clinical trials should justify the use of proton therapy in combining use of MR guidance. I'd like to take this opportunity to thank deeply the radiotherapy team and the physics team in our hospital. They have been extremely professional to provide excellent care to our cervix cancer and gynecological cancer patients using MR-guided radiotherapy. Thank you.